to a different, maybe some problem.
Dr. Lipi and Dr. Panna, please start. I think we are already 7:30.
Good evening, everyone. I'm Dr. Lipi Mittal. I'm extremely sorry for my bad throat today. So, I welcome you all to the 13th session of Learn from the Master by ASG Academy. So, before we begin, let me introduce you to the academic cell of ASGI hospitals. We have Dr. Kaushik Tripathi, sir, Dr. Ganesh Pile, sir, Dr. Mayank Sharma, sir, and Dr. Atul Dhawan, sir, with us. You can scan the QR code and you can also subscribe to the YouTube channel, and where you can avail all the videos and lectures available from all the masters. So earlier we have had multiple sessions from the masters of international masters, retina lectures, as well as Indian masters. So tonight we are privileged to have with us Dr. Sourabh Patwardhan, sir, whose YouTube channels we are following since the very beginning of our residency. We welcome you, sir. I request my co-moderator, Dr. Aparna, to introduce sir. Dr. Aparna.
Thank you, ma'am. So we all have been following Sir's famous YouTube channel, that is Phaco Tips, and it has a huge collection of over 2,000 videos. It doesn't only include teaching videos, but it also has a collection of videos in which you can learn how to go through your training program, what mental things you need to change, and what mindset you need to keep while going through your fellowship. So, Sir is someone who doesn't need any introduction, and he is a cataract, retina, and glaucoma specialist at Nandadip Eye Hospital in Sangli. He is also the director of fellowship program at this hospital. Sir has done his MBBS from St. GS Medical College, KEM, Mumbai, and he topped in his state final exam as well. Sir did his MD of ophthalmology from the prestigious RP Center of Ophthalmic Sciences, New Delhi, and passed with a gold medal. Sir completed FICO in April 2008 and was also awarded the honorary International Council Scholar designation. He conducted an instruction course in CME on multifocals at Goa. Sir has been also the proud recipient of PK Khosla and LP Agarwal awards, and has also been the winner of the annual DOS Quiz in 2009. We are also lucky to have our set of esteemed panelists. To begin with, Professor Dr. Lionel Raj D. He is the medical director at Dr. Agarwal's Eye Hospital, PG Institute of Ophthalmology, and Dr. Agarwal's Eye Bank at Tirunelveli. He is one of the leading corneal transplantation surgeon in the world and has a research fellowship from Spain in corneal refractive surgeries. Sir has also a patent in implantable sustained release antimicrobial discs for corneal infections. He has also been accorded with the professorship from National Institute of Health at Zanzibar. Active member, he is an active member of various national and international ophthalmic societies and has more than 76 publications in peer-reviewed and index journals to his name. Sir has also guided a number of postgraduate students in his domain and has received many international and national awards in the field of ophthalmological research.
Thank
Next,
you so
welcome.
much. Thank you so much for your gracious invitation.
Thank you, sir. Thank you for being with us. Next, we introduce Dr. Gaurav Dubey, sir. Sir has completed his DNB from Sir Gangaram Hospital and his DO from the Regional Institute of Ophthalmology, Sitapur. Sir is the director at RK Devi Memorial Hospital and has performed over 25,000 phaco surgeries. He has also done his observership from the prestigious RPC Ames Center for Cornea and Cataract. He has also done a short-term training for keratoplasty in Mumbai. Sir headed the joint team for identifying the prevalence of primary ocular tuberculosis in Kanpur with Dr. Rupesh Agarwal, and Sir has been always actively involved in teaching and training the phaco trainees. Welcome, sir. Next, we have Dr. Jatin Ashar Sir. Sir is the Medical Director and Chief Operating Surgeon with expertise in cataract cornea refractive surgery at Mumbai Eye Care Hospital, Ghatkopar in Mumbai. He has expertise in complex cataract surgeries, phacoemulsifications using premium IOLs, as well as pediatric cataract surgeries. Sir was the youngest Indian surgeon to be invited to the American Academy of Ophthalmology. He has been credited with numerous awards and publications in international journals. Sir has even executed corneal transplant in a baby as 1 month old and carried out many refractive surgeries. Sir has received Achievement Award and International Ophthalmologist Education Award from the American Academy of Ophthalmology. We welcome you, sir. Next, we have our own Dr. Mayank Sharma, sir. Sir is the Medical Director and Induction Cell ASGI Hospitals and as well as Academic Cell at ASGI Hospitals. Sir is the mentor of the program, fellowship program running at ASGI Hospital in phacoemulsification and refractive surgery. He is also the member secretary of the ethics committee at the ASGI hospitals and secretary and chairman of the scientific committee of Jodhpur Ophthalmological Society. Sir is executive member of ROS at Jodhpur zone and he has specialized in phacoemulsification, flax and refractive surgery. Thank you, sir, for being with us today. So without any further ado, we move ahead with our session with Dr. Patwardhan, sir. Sir, please enlighten us on phaco.
Hi, good evening, everyone. And I think we have such a distinguished panelist. So I think we'll have more of a discussion rather than me telling few things about FACO. FACO is now, I think everybody knows in and out about FACO. There is nothing more to add. I will start with some of the videos. I think maybe after each video, panelists can give their views, so I can also learn from that experience. So I will start with my first video, which in fact was one of the first videos I made for my channel, or when I decided that I should, start sharing whatever I learn. So one of the questions which was asked by at that time my fellow was that, the biggest, I would say kind of we are worried about is the PC rupture, which is very troublesome because that is what we are afraid of when we start doing phaco. And he was asking like, can we prevent a PC rent? Is it can we prevent it 100%? What are the ways to prevent it? So I thought that let me just go back and see like how I changed my technique so that I have least PC rates in my own cases. So I'll start with my first video here. I will share the screen now. Hello friends, I'm Dr. Sourabh Patwardhan. Hope the audio is Eye Hospital there. PG Teaching
Yes, sir.
Institute and Phaco SICS Training Center, Sangli, Maharashtra. In our center, we have a lot of. In this video, I'll be speaking about the general thought process behind reducing the chance of posterior capsular rupture in case of phacoemulsification. So there are many things we should know before we start any surgery, and these are the basics. So we should know what are the common mistakes which are going to lead to complication during a routine case of phacoemulsification. And
Sir, the sound has stopped.
Stop.
that means where we do not expect. Is it working now?
Yes, sir.
Excludes all posterior polar, subluxular, traumatic cataract, etc. So these are the routine cases, and in these cases we should not have any complication. So what is the PC rent philosophy that I follow? I think PC rent in a routine case is 100% avoidable, but provided that we get a chance to go back in time. So of course that is not possible. So we'll still get PC rupture in a routine case occasionally. But what we should do is that we should do surgical audit and find out the cause so that we prevent it next time. when we encounter similar situation. It is important to understand the anatomy of anterior segment. Many of us don't know the exact thickness of the lens or the size of the lens which is there. So usually adult size lens has a diameter of around 9 to 10 millimeter, and the lens thickness is 3.5 millimeter at birth, and which increases by 0.02 millimeter every year. So generally in adults, say 50 plus years of age person, we expect 4.5 to 5 millimeter of the thickness of the lens, and it may go even higher to 5 to 5.5 in case of intumescent cataracts where the lens has thickened quite a bit. In younger patient, we may expect 4 to 4.5 millimeter thickness, like for example, 20 to 40 years of age. So when we are looking at the patient's age, we also should understand what will be the length and the thickness of the nucleus. And this thickness is very important because we know that as in case of an adult nucleus, the central 3.5 mm is the I would say more denser part of the nucleus generally, and the anti-epinucleus is around 1 millimeter and the posterior epinucleus is around 1.5 millimeter. So once we remove the anti-epinucleus, which is 1 millimeter, we need around 1.75 millimeter deep trench to reach the center of the nucleus. So that is the use of understanding the anatomy of lens. So 1.75 is approximately 2 tip width size because we use generally tip width of 0.9 millimeter. Now, how to know that you have reached a proper depth in case of trenching or softer and harder cataracts? So depth by taking the tip width is yardstick, and also second thing is improved red glow. So as you go on trenching, you may see improved red glow, particularly in softer grade of cataracts. But if it is a moderate grade or hard grade of cataract, sometimes what we see is that there is decreased resistance to the phacoprobe once we trench beyond the central hard part. So three things to remember: the depth by taking the tip width as the yardstick. Second is the improved red glow, and third is whether the resistance to the trenching has reduced after passing through the central hard part. Now, what is the safe zone? This is a very important anatomical term. So it is the central 4 millimeter zone. So in this zone, the anterior capsule or the anterior chamber is deepest. So that is the area. If you put your phaco probe right at the center of this zone, it is away from the cornea as well as posterior capsule, and there is more room for maneuvers, and there is safety cushion from the surge even if PC comes up. So you are keeping the endothelium as well as the posterior capsule safe if you do all the maneuvers within this safe zone. So stable anterior chamber is must for safe phaco. And how do you achieve that? By having adequate inflow and controlled outflow. Now, inflow must match the vacuum and aspiration rate parameters. If you want to increase the inflow, increase the water light, that is IOP. Sleeve should be appropriate size and should not be getting compressed in the wound. Irrigation pores should always be inside the anterior chamber during phaco. Now, how do you control the outflow? The incision should not be excessively leaky. So use appropriate MVR size. For example, I use 23 gauge MVR, so leak is minimum. And vacuum should be again appropriate for the inflow which we are going to provide. Now, many surgeons ask me what is the safe vacuum or aspiration rate or phaco power. Then it varies from machine to machine. Okay, but you have to titrate it for that particular machine. Now, what do you mean by linear mode is that the increasing vacuum will be according to the foot switch. If you press more foot switch, the vacuum will increase. If you use a panel mode, then it is a fixed vacuum. That means the moment you press foot switch, it will reach the highest set vacuum. So the safe parameters for the machine should be set by the surgeon by checking the surge and stability of the chamber during the initial cases. So once they are set, you try to use those only. Phaco power should be optimally set. It is very important to avoid excessive power, particularly in softer grade of cataract, as it can lead to cut through and it may cause damage to the posterior capsule. Keep the maximum power reachable fixed as per the grade of the cataract. and keep a linear mode as density of nucleus varies from center to periphery. Maybe initial cases you can ask the trainer or your supervisor to fix the power for you. Visualization is very important during Phaco. So if you don't see, you don't operate. So if there is a small pupil which is obstructing the visualization, it should be enlarged by different ways. I think simplest thing is to use iris retractors. The small pupil not only hampers visualization, but it will also hamper the good fluidics. It's very important to use appropriate viscoelastic agents. Remember that cohesive viscoelastic agent do not protect endothelium, so always use dispersive ones for protecting endothelium. And in certain cases, when you have excessive surge and redundant PC, you tend to do more anterior phaco, though it's not desirable. But in such cases, it's very important to protect the endothelium with heavy dispersive agents like Viscoat or even Helon 5. And in case of non-availability of these viscoelastic devices, you should inject the routine dispersive agent like 2% HPMC frequently so that you avoid any damage to the endothelium. So this was about the part 1 and the basic thought process behind reducing the chances of posterior capsular rupture during phacoemulsification. Okay, so this was my first video. I think you must have thought that this is a very basic video, nothing more. But what is surprising is that most of our PC ruptures or complications occur in our regular cases when we don't look into each of whatever has been said in the video. When we overlook even one part of it, we'll have more complications. So first important thing is to follow all the rules, 100%, so that we have the least possible complications. The moment we have least complications, our confidence grows and we become better and better in our surgical skills. Kaushik, anyone from the panelists would like to add anything or would like to comment on the video? After that, I will go to the next video.
Well, that's a wonderful presentation, enumerating the basic steps of phacoemulsification. And it cannot be just taken as a very basic because it's a learning for me too, because adjusting the depth in accordance to the size of the phaco tip that we are employing, that is something new to me also. So that's an interesting story. And the recent day phaco systems, they also incorporate real-time vacuum-based pump, active pump, rather than gravity-fed fluidics. So that is something which is also an additional advantage with the recent day systems. And of course, assessing the depth, adequate hydrodissection, and understanding the basics of the lens, and also um do something which you visualize. So all these are very key elements which have been very well narrated.
Thank you, sir. Thank you.
I think one point which I would like to highlight is that your preparation for the case begins at the slit lamp examination. You should be in your initial phases of doing cataract and phacoemulsification, do a very thorough, detailed slit lamp examination and identify, as Dr. Saurabh said, the red flags which you might encounter, such as the cornea might not be very bad, but a slightly hazy cornea, or pupillary non-dilatation. The anterior chamber depth is also very important. Initially, we should avoid these cases, taking up these cases in which the AC is shallow or the cornea is not very healthy, the patient is very old, deep set eyes, hypermetropic eyes, smaller eyes. So we should flag off these cases initially only, and then take up good, clean cases, grade 2, grade 3 in the initial training part. I think, and the rest of the things were very wonderfully elaborated by Dr. Saurabh. So,
Okay. Should I move on to the second video?
Yes, sir.
Hello friends, I'm Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute. So always check to avoid some thinking about certain good habits which help you during phaco surgery to avoid some common complication. So always check the irrigation bottle first that it is full and proper height. Check all parameters. Check that sleeve and tips are properly configured and check that tubings of the phaco and eye probe are tightly attached before you start the surgery. Start with good size CCC. If CCC is too small, always make sure you enlarge it before doing hydrodissection and plan the steps as per the grade of the cataract. Always keep the phaco probe in safe zone. Keep the dominant hand as steady as possible and use non-dominant hand for maneuvers. Always enlarge the small CCC because it hampers good fluidics. The nuclear maneuvers are difficult and can put stress on zonules. How to enlarge the CCC? It's very simple. You can use either vanas or microcapsulexis scissors, and you can make a tangential nick. Always try to make a tangential cut rather than radial, and then use visco to lift the tiny flap, and use microcapsulexis forceps now to hold this tiny flap there, and then enlarge the capsulexis to desired size. This is a very important maneuver which everyone must learn. Once we have adequate size CCC, we notice that the number of complications significantly reduce. So it is always important to start with good size CCC. So always keep these micro scissors and micro capsulexis forceps in your instrument tray. Now always use the non-dominant hand, which is holding the Sins key to maneuver the pieces around the phaco probe. It is very important not to move the phaco probe around. The non-dominant hand used for maneuvers reduces the instability of the anterior chamber, and also you keep the phaco probe in the safe zone that reduces the chances of posterior capsular rupture. So for achieving good fluidics and stability of the anterior chamber, always train your non-dominant hand for these maneuvers. Keeping the phaco probe in the central 4 mm safe zone is utmost essential, and you can see your videos again and again to check whether you are following that rule, because if in between you are going away from this safe zone while you are doing phacoemulsification, you will always find that your complication rates will increase. Though when you leave the safe zone, not necessarily that every time you will have a complication, but we must understand the complication rates are high if you leave the safe zone. Use IA probe for epinucleus or cortex if you feel that the anterior chamber is not stable. So avoid using phaco probe for soft cortex or epinucleus if you feel it is risky. You can see here the surgeon tends to go away from the safe zone occasionally, though the surgery might be uneventful in most cases. There will be high risk of posterior capsule rupture, like in this case where the surgeon left the safe zone and caused punch in the posterior capsule. Now, for achieving safe chop, what is important is that you bury only the exposed tip, and after burying the tip, only keep the aspiration on and don't give phaco when the tip is buried. So phaco is on when you bury into the nucleus, but once you are buried, you have to keep only aspiration on and stop the phaco power. If you continue to do phaco when the tip is buried, there is chance that you may punch through and cause a posterior capsular rupture. Always make sure that you complete all the chops before going to quadrant removal, because the nucleus itself protects the posterior capsule in case of sudden surge or uncontrolled chopper movement when the nucleus is there when you are chopping. So never give phaco once tip is adequately buried, as it may lead to punching a hole through the nucleus and to the posterior capsule. Like in this case, you can see that tip is buried, still the surgeon continues to give phaco and causes a punch and causes posterior capsular rupture, as you can see with that pupillary dilatation which happened. Now for the last piece, we know that the commonest time when the surgeon gets posterior capsular rupture is while emulsifying the last piece, because it's an unsupported piece. Now the preparation starts early, where you watch for the surge when you are starting chopping or doing quadrant removal. Now just watch here as the surgeon tries to do the chop and then doing quadrant removal, you find that there is surge. So it's important for the surgeon to notice this surge. You can see that pupillary constriction, fluctuation in the anterior chamber after there was occlusion break, which indicates that the inflow is not sufficient enough to cover the vacuum which is being generated there. So reduce the vacuum, increase the bottle height, and once you do that, you find that the surge is not there now as the surgeon continues to emulsify the other pieces as the parameters are now modified. As the chamber becomes more stable, now it is safer to emulsify the last piece. So the preparation for the last piece begins quite early during phacoemulsification, and you must keep watch on the anterior chamber fluctuation and the surge and reduce the vacuum and increase the bottle height as per the need. So watch the chamber fluctuation during chopping, reduce the vacuum, flow rate, and raise IOP to reduce fluctuations and surge, and thus we can avoid the posterior capsular rupture. When you're chopping the initial nuclear pieces, the posterior capsule is pushed back by other pieces. So rest of the nucleus works like a spacer and prevents posterior capsule from coming anterior and hitting the phacoprobe. But when it comes to the last nuclear piece, there is no spacer between phacoprobe and posterior capsule. Hence, the fluidics should be stable and the position of the phacoprobe should not be too posterior and it should be central. So these are very important things to understand to avoid last piece bend. So before the last piece, always try to emulsify one nuclear piece on the side of another piece. The other piece works as a spacer, keeping the posterior capsule away. In other words, only last piece should behave like unsupported last piece. This is a very important statement to remember. So when you're emulsifying one piece, you drag the other piece on one side. So it keeps protecting the posterior capsule. As you keep watch on the fluidics, everything is under control. There is no anticipated surge and you can emulsify the last piece comfortably, keeping the phaco tip right at the center in the safe zone and making sure that there is no surge happening when you are emulsifying the previous pieces. So the strategy for the last piece is chop all the nucleus before starting emulsification of pieces, anticipate the surge and reduce vacuum or raise IOP and prevent surge for the last piece. Emulsify one piece on the side of another apart from the last piece, which needs to be protected by good phaco-dynamics. Now, once you implant the IOL, make sure that the IOL optic case should be in the bag. So this is one more mistake we should avoid. Before you close the surgery, make sure that the optic is completely in the bag and it's not coming out of the bag. This is good for the refractive stability later. Always make sure that the incisions are well hydrated and there is no AC collapse even after removal of the speculum. Else it may lead to postoperative hypotony and higher chance of infection later on. So make a habit of confirming that AC is well formed after removal of the speculum. In case of a posterior polar cataract, you can see after removal of the nucleus and cortex, you can find that there is a pre-existing PC tear. Now here we must do aqueous visco exchange in order to avoid further extension of this PC tear. So stop the irrigation as you start injecting the OVD and make sure you have practice of doing this even in routine cases, because once PC rent happens and you don't inject OVD, you can see that the PC rent enlarges as you withdraw the phacoprobe. It's always important to learn this trick while doing routine cases as well. So these are some of the good habits that we must try to inculcate while doing phacoemulsification surgery. Thank you so much.
Yeah, so that was my second video, again telling about the very important good habits. And what happens is that when you try to inculcate these habits, it becomes a discipline. So once it's a habitual thing, you avoid those mistakes, or I would call silly mistakes, which lead to more complications. And every time you analyze your video with any complication or even a video without complication, uneventful surgery, when you analyze this and you look into these aspects, that whether you were 100% correct in all the maneuvers. If you keep analyzing this, your surgeries become much better, well, more skilled, and your complication rate as well as your success rate also increases after that. Okay, over to panelists if yeah, they would like to.
I'm Lionel again. Again, well narrated within a short course of time. To put it in a nutshell, what I said, essentially, optimal incision size is very key. Then optimal phacodynamics, phacofluidics. So this you highlighted very well, and also the central zone, the safe zone where phacoemulsification needs to be done. And maybe I have a couple of additions when it comes to the last fragment, the last piece. We call that as last piece syndrome, and especially when the uh, the subnuclear cushion effect is not there in mature cataracts or hypermature cataract. So there are a couple of ways we can add preventing PCR. One is use adequate viscoelastics to float the last fragment into the safer zone, the central zone, and then go for emulsification. And another useful technique which is been popularized and been followed by many of the surgeons is having an IOL injected, the leading haptic into the bag and the trailing haptic either outside of the bag into the sulcus or even externally. Having this IOL as a scaffold creates another cushion between the last fragment and the posterior capsule, especially when the capsule tends to float up anteriorly. So that's also an effective way that we can manage the last piece syndrome. And regarding the PCR, when there is a PCR, it's an inherent tendency of the surgeon to remove the probe out. That shouldn't be done. Keep the probe inside. Adequately inject viscoelastics through the second incision and then slowly get the probe out. That is very well highlighted, and that is something which needs to be followed at all times. Thank you.
Thank you, sir.
So we have few doubts from the audience.
Yes, please.
So the first question is, do you suggest any change in technique when one is shifting from a balanced tip to Kelman tip?
From the which tip? Balance tip. Okay. So what I gather is that in the Alcon machine itself, they want to shift from balance tip to Kelman tip, sir. Is that right?
Yes, sir.
Okay. So one more important thing about balance tip is that it delivers much higher energy for the same power settings as compared to Kelman tip. So for example, in if you are using say 100% energy in Kelman for say hard cataract, the same can be delivered at 70% for the balance tip. So if you are shifting from balance tip to Kelman, you have to use higher power. So other way around, if you are shifting from Kelman to balance tip, you have to reduce the power which is to be used. Otherwise, with balance tip, if you use 100% power, sometimes you may get iris chafing or excessive energy dissipation and corneal edema. So that has to be important. Now, balance tip is made in such a way that it's more straight as compared to a Kelman tip. So probably you might have to adjust little bit if you are going to trench with a balance tip, and with Kelman tip it might be little easier, but it's matter of just couple of cases to get habitual to it. Balance tip provides much stable anterior chamber according to me as compared to Kelman. But most important feature of balance tip is the power delivery. So even the hardest grade of cataract can be easily emulsified by the balance tip as compared to Kelman tip.
And if I have to add something to Dr. Sharap's statement, the basics doesn't change. Whether it is a balanced tip, a straight tip, a curved tip, Kelman tip, the basic doesn't change. So the basic of the phaco process, the phacoemulsification process is the same. Only thing maybe like if there is a torsional component added, then it is kind of what we teach for the residents is once you occlude, once when your tip is occluded with your nucleus fragment, then go and give whatever amount of full energy you want, the phacoemulsification energy. Whereas with torsional phaco, the company and the system wants us to continuously use phaco energy, whether it is completely occluded or not occluded. So that may be the only reasonable change. Otherwise, the process of phacoemulsification is the same.
So the next question is what points to keep in mind while switching to a Venturi machine?
Yeah, so it's very important because I find because we use Constellation, which has a Venturi mode, and we have other machines on peristaltic like Legion and Earthly and Centurion. Now, with Venturi, everything will be little faster. Okay, so it is something like the reflex time. So you might have seen these shooters, or they have to shoot within a very short period of time. So those shooters who have got very fast reflex times, they can shoot multiple targets easily within a short period. And same thing maybe for another person, his reflex time is little slow, so he may not be able to shoot that many, targets in that defined period. So in peristaltic, basically we have more, time to react because peristaltic pumps have a certain limit at which they can, run. Above that, they cannot run fast. So there will be always little bit of time gap to build a, vacuum or the vacuum or the hole. But of course, with the newer machines, when you use very high flow rates, it is also minimum. So if you use say 50 or 60 flow rate on say Centurion, it will work similar to a Venturi machine because the rotors are also moving very fast. Now but the good thing about peristaltic is that you can always control this flow rate and vacuum separately. So you can have say 500 vacuum, but if I want the things to go slowly, I can reduce the flow rate say from 40 to 30. So things will happen little slowly in the chamber. So I have more time to react if there is any fluctuation or if I want to change something. Now in Venturi, you cannot change the flow rate. So only thing which you can control is the vacuum. More vacuum you use, more will be the flow rate. So you cannot have say 300 vacuum, but I want things to happen slowly. That cannot be done with a Venturi machine. So if you want to do things little slower, you have to reduce vacuum only. But when you reduce vacuum, the fallibility also is reduced. Okay. So the advantage of peristaltic is that you can control flow rate and vacuum separately, and which is two advantages for surgeons who want to do surgery in more controlled manner. Now in Venturi, because you want better fallibility, you have to keep certain vacuum, but with certain vacuum, the flow rate is also going to be high. So whenever you press the foot switch in Venturi, it is trying to reach the highest vacuum immediately. While in peristaltic, because of the flow rate constraint, it will reach it little slowly. Okay. So for Venturi, if you are shifting from peristaltic to Venturi, initially use lower parameters, lower vacuum to begin with. So say for example, on peristaltic, if you are used to 400 vacuum, okay, I would advise that you start with 200 vacuum with Venturi. Don't start with 400 because 400 will be very, very fast on Venturi. Okay. Second thing, with Venturi, you will always require more inflow of fluid because in case of peristaltic, once the tip gets occluded, then only you will have hold and you will have rise in vacuum. In Venturi, vacuum will rise right from the beginning. So it is going to take out lot of fluid. So you need good bottle height or good IOP control if you are using Venturi. Okay. But Venturi is very good in the terms that it has best fallibility. So what is the advantage of Venturi is that you don't have to fetch pieces. Okay, so you don't have to go to the periphery and pull out the pieces. You can stay at the center, and because of the Venturi, the pieces will follow the tip. So what you should change when you are shifting to Venturi is that try avoiding going away from the safe zone at any time. Okay, just stay at the center so that the vacuum itself will do its job. Okay, so these are the two different things. So I use Constellation with Venturi and Centurion with Peristaltic. Both are excellent machine, but you have to remember that these are the parameters that you have to watch.
Yes, exactly. The peristaltic, the basis is once with full occlusion, the vacuum goes high, whereas in Venturi it is linear, just like a throttle. Keep pushing the foot pedal down and the vacuum pulls up. So peristaltic is a little forgiving machine. Venturi is super fast in case of in terms of performance. So this is how we can tell.
So just to add, maybe for the beginners, this is quite useful. What I found in my students is that they used to have complications more when they're doing quadrant removal more often because they try and fetch pieces from the periphery. And that's where, suddenly they will give some phaco burst and they will have a peripheral rupture. So what I do is that in our center, we keep the vacuum little on lower side for the peristaltic machine, but we use little higher flow rate. Okay, so that the followability is good, but the vacuum is moderate. So we have seen that it has reduced the complications happening during quadrant removal. So that is a good thing that we can do it in peristaltic machine, which of course we cannot do it with Venturi machine.
Thank you, sir. We have one more question. Your tips on phaco polishing and cortex aspiration. If you could share some tips on that.
Which polishing?
Polishing and cortex aspiration.
Cortex aspiration.
Cortex
Okay,
removal.
of
Yeah.
course, it's another big topic. Maybe I have to show video, but with cortex aspiration, one trick which I follow is that many times we see, surgical videos in 2 dimension always. Okay, where you feel that you go to the peripheral, you hold the cortex and you pull to the center, right? But I think it's a very good idea to hold this cortex in the periphery and pull it little posteriorly. Okay, rather than only centrally, pull it little posteriorly. So what happens is that it peels that peripheral cortex, but the fluid itself will pass through this cortex and the anterior capsule, and it will completely release this cortex from the capsule. Okay, so if you get the idea right. So in this, two things happen. One thing is that cortex gets separated very easily, very fast. And second, because you are pulling away from the anterior capsule in the posterior manner, the chances of dialysis, which happens when you pull centrally, because if you pull centrally, there is a chance that you may, hold the anterior capsule and pull it centrally. It will never happen when you pull the cortex posteriorly. So I think you can try this tomorrow also in your OT, and you will find that it works very well. So for cortex aspiration, that is a very good thing. And another thing which I have read somewhere, I think for cortex removal, what we have to remember is that you cannot pull the entire elephant with the tail. That's what I have read somewhere. This was a good, I would say, simile. Whenever you are pulling out the cortex, the first thing, the first step you have to look into is whether the tip is getting completely occluded by that cortex. Okay, many times what I have seen is that surgeons tend to do it very fast. That means they go into periphery and just start, moving the IA probe very fast. But what is most important is the occlusion of the tip with the cortex. So wait there for, some split second, let the cortex occlude that tip, and then you can pull it. You will find that going slow is more efficient than going fast for removing this cortex. So I think these two tips will be quite useful.
I think one very important aspect which we can do before starting the cortical aspiration is that I had seen Dr. Basavada sir's videos and they were very helpful, especially in thick epinuclear plates and sticky cortical matter. We can do a secondary hydrodissection also after the nucleus has been removed. So we go just below the anterior the capsular excess margin and inject a little bit of BSS solution that tends to loosen out the cortical matter and probably a little bit of epinuclear plate also. Eventually, we can do also a visco dissection also, inject a little bit of viscoelastic. So the whole cortex gets loosened out and a little bit of epinuclear plate also just floats up, making it easier for the removal of the cortical matter. So that's because at the end of the day, our aim is to make the surgery as safe as possible. So that's one tip which can be used by the beginners initially.
Yeah, for me, I would say, the IA tip should be, one should be very cautious that the tip is facing up and not down. Secondly, as Dr. Saurabh said, go to the periphery and be comfortable there and ensure that the tip is occluded with the cortical matter. Bring it to the center, always bring it to the center. Catch, bring it to the center. Ensure that it's not capsule, it's only cortical plate, and then give more vacuum and aspiration. So this is one thing. But most often where irrigation aspiration would go difficult is with the subincisional cortex. So one way of managing subincisional cortex is having a bent tip, IA tip. The second way of managing subincisional cortex removal is having a bimanual irrigation aspiration cannulas. And the third way is if everything goes very difficult, you can always have a side port incision 180 degrees or 120 degrees away from your primary incision and use a Simke cannula and you can remove the subincisional cortex. So that is one challenge that surgeon might face. The second challenge is sometimes when there is equatorial calcification. So if the cortex has equatorial calcification, then it's tough. It's more adherent to the capsule in the equator. So that is sometimes when you get a struggle. So that comes out of your experience, how much amount of pressure you need to give, amount of vacuum you need to give to bring it to the center. So that is about, those are two difficult scenarios for INA that I generally say. And the second part of the question is related to polishing. So polishing of the posterior capsule, you can use low vacuum settings and try to polish with the IA probe. That is possible. Use certain instruments like polisher, PC polisher, and go ahead and polish. Even you can use some viscoelastic to slightly rub over the posterior capsule where you see if there is posterior capsular remnants or cellular remnants are left over. So these are some of the ways that you can polish posterior lens capsule.
Thank you, sir, for these practical tips. Another question is that how to prevent posterior capsular rupture in soft cataracts, which are very difficult to chop. So, what precautions should we take there?
Yeah, I think for soft cataracts, I think the best strategy nowadays what I use is the hydroprolapse. That means after doing the capsulorhexis around at least 5 mm, I do hydrodissection, then hydrodelineation, and then I slowly inject more fluid so that one of the pole prolapses out, and I just do phacoaspiration. I think that has worked for me quite well. Uh, that usually is easier in very soft cataracts, a grade 0 to 1. Sometimes there are cataracts which are very soft, but they are more compact. So you don't get the hydrodelineation very easily. Those are the cases where you may get stuck in like a bowl. Okay. So the typical case where you can expect this is a cortical soft cataract, because in these cases you don't get the hydrodelineation and you're always afraid to hydroprolapse because the entire mass is so big that if you try to inject more, you can have a hydrorupture of the posterior capsule. Okay. In those cases, I think best technique is still either trench divide or horizontal chop. That means if you are, but for horizontal chop, you have to be well versed with it. You should have a blunt chopper and you should do it. And many beginners they find it little difficult. So you can do the standard range divide. The only issue is here that there will be a lot of cheese wiring. Okay. Now to avoid cheese wiring, I use a technique where I have a longer 1.5 millimeter chopper and it is blunt chopper. And once I make a, very thin and deep groove, I use this chopper in such a way that the chopper lies horizontally into this groove. Okay. In that way, the cheese wiring is less. So remember, the cheese wiring happens more when the area of the chopper which is introduced is smaller over the lateral side of the this trench. So if you introduce larger surface area, which happens when you put it horizontally, the chances of cheese wiring are less. And once you get two heminuclei in soft cataract, you can just aspirate them out. You don't have to try to further divide. So I think three, four techniques which work. One is the easiest is the hydroprolapse. Once you have hydrodelineation and hydroprolapse, it is the easiest, and which I do almost in 90% of my soft cataract. Second, as I said, was to make a horizontal, chop where I go negotiate the equator of the nucleus and chop the pieces. Third is this very thin trench and then divide using the horizontal placement of the chopper. So I think these three things work. Sometimes you still get into bowl. Okay. So once you start feeling that you cannot take it out, avoid try to pull these pieces from the periphery. That means don't try to chop these soft cataracts trying to hold the nucleus, which is very soft, because high risk of punching through is there. Okay. So in that case, what you do is that you create a complete bowl. So if there is a bowl already, you try to, emulsify further and make it very thin. And after that, you can again do hydroprolapse or viscoprolapse, because once the bowl is very thin, it prolapses out easily. But before that, I think the most common mistake done in soft cataract is making a very small rhexis. Okay, this is like a vicious cycle. So you have a soft cataract. So patient has usually good vision. Now you are anxious that I don't want a complication in this case. So you don't want a rhexis run away. So you make a very small rhexis, 4 millimeter. Okay, and then you don't get a good hydrodissection also, or because if rhexis is very small, you cannot inject much of fluid because there is a chance of hydro rupture. So it's like a vicious cycle. So in that case, if there is a bowl formation and the rhexis is very small, you can enlarge the rhexis again. Okay, this happens with some of our trainees that they start with the case and rhexis is very small. So what we do is that we enlarge the rhexis in between. Once the rhexis is enlarged to 5 millimeter, you can prolapse that nucleus also very easily and you can complete the case.
Rightly said, Dr. Sourabh. If I have to cut an apple, I use a fork to stabilize the apple and slice it using a knife. So this happens only if the nuclear substance is adequate. When it's very soft, then it doesn't work well all the time. So the key tips are: one is adequate capsular access, number two is adequate hydrodissections, and the third one is judicious use of non-dominant hand. That is also very important. In such cases, when someone is ambidextrous using both hands very well, then they come out very easy.
Yes, sir. Somebody was asking about the balance tip on Laureate. So balance tip is basically meant for OZIL machines. So it will not work well on any machine that is using only longitudinal. Okay. So I think you should not try. But most of the machines using OZIL, you can use the balance. Yes. Any other questions? I would like to just show one last video if we have
Yes.
time.
Yes, sir, we do. We do.
Yeah. So another important thing is, to have the best surgical outcomes, we have to be very optimum in what we do. Many times, we sometimes try to be excessively cautious. Okay. And that I feel is also one of the major problems for being slow learner. Okay. So I have trained so many surgeons now. So there are one extreme who are absolutely casual or careless about what they are doing. So they will do one complication and forget about it immediately, and they will do another. Okay, not thinking about what happened earlier. And there will be another extreme who are so cautious or so, I would say, hesitant about having a complication that they will not be able to do a particular step also perfectly. So the most common thing which I see that they don't do a deep trenching. Okay, because they are so hesitant that they will get a complication. And in order to have reduced complication, in fact, they do more complications, because right way to have is the optimum way of doing each and every step. Okay, so I want to just share an interesting video about whether excess, doing something excess is also good or no. Okay, let me just share the desktop.
This video is intended for education and training of eye surgeon. Viewer discretion is advised and not recommended for children. Hello friends, I am Dr. Sourabh Patwardhan from Nandadi Eye Hospital and Phaco Training Center, and this is a very interesting video. So let's see what happened in this video. So this is a video shared by my colleague, and he's operating on a relatively younger patient, around 45 to 50 years of age, very well dilated pupil, you can see here. And in very dilated pupil, you tend to misjudge the size of the rexis, like here in this case. Colleague is doing the rexis well, but it's too big. You can see that it's already quite big, which he realized now, and he's now trying to bring it down to a size that he wants, and it's going smoothly. No problem till here. And he's doing very well. He's not pressing the posterior lip much. And visco is well filling the anterior chamber. But here, the colleague thought that he will replenish the OVD a little bit. He is using 2% HPMC. So he thought that he will push some more HPMC here. And oops, what happened there? That was not something he was expecting. So obviously he was stunned. I'm just contemplating now how to proceed further. But just have a look at this, what happened. Pushing the HPMC in the anterior chamber, inflating the anterior chamber there, and capsule rexis just goes radial right there. So what could be the possible explanation for this? So obviously now the colleague is thinking of how to go ahead, but we'll think about what really was the explanation for this happening. The real reason behind this is, I think, overinflation of the anterior chamber, particularly in a case where the scleral rigidity is less. So when you overinflate the anterior chamber with OVD, particularly HPMC, what it does is that it is going to stretch the sclera. It is going to stretch the zonules. Zonules are going to stretch the anterior capsule out. And that's why the tear of the capsule rexis is going to go radial out. So that's the reason in this case. Have I seen it before? Yes, I have seen it before in certain cases. So this is not something unexpected. So anything in excess is always bad. I have observed it happening in intumescent cataracts, particularly in young patients. If overinflation of AC is done with 2% HPMC, the outgoing capsulexis goes further out. And it's always better to use heavy OVD than HPMC in case of impending CCC extension, as it can put weight on the capsule without need of overinflation of the anterior chamber. And in case of using 2% HPMC, avoid the temptation to overinflate AC, particularly in eyes with a lower scleral rigidity. And anything in excess is bad. Try to maintain the anatomical position of the anterior chamber as it is throughout any eye surgery. For more such videos, do subscribe to my YouTube.
Okay, so that was my last video for today. So that was the message. I think we have to have optimum, everything to be used optimally.
Can I add something, Doctor, here?
Yes, sure, sure.
Interesting case video, and maybe some additional points if I have to say. Whatever substance that we inject into the anterior chamber, the cannula should be directed either towards the angles of the anterior chamber, or in this particular case, when we use OVD, it can even be directed little anteriorly towards the corneal endothelium. I wonder if there was over injection of viscoelastic into the capsular bag. That also could be a reason for rhexis loss and rise in intralenticular pressure and rhexis loss in this particular case. So always use OVD judiciously to flatten the capsule, not to make the capsular flap floating into the AC, but at the same time, take care that it's not the direction of the cannula is not directly facing towards the intralenticular substance.
Yes, sir. Of course, in this case, of course, it was a compact nucleus, so nothing went into the lens per se. This is already described as a reverse Argentinian flag sign, which happens when there is overinflation of the anterior chamber. And what I find is that actual intumescent cataracts are few. Most many times, young surgeons they will overinflate the anterior chamber and make it worse.
Got it. And always my professor used to tell, medicine professor, less is more. Sometimes using less of agents or medicines is more better for the patients. So less is more.
Yeah, I think the word is optimum. We cannot use less or more. We have to hit the optimum.
Got it.
That's the difficult part.
Yeah.
And sir, another thing is that we can settle for good rather than aim for perfection in
Yeah.
surgery.
Yes.
Perfection may be the like opposite to good. Like if you have done surgery, PC is there are fine strands and you are trying to remove that and there is a PC. So with practice, we know that yes, the surgery is good or good enough, it is okay. It is not like you do not need to be perfect or perfectionist in surgery, at least for initial 1,000 or 2,000 cases. Because aiming for perfection or aiming to do everything like perfectly, then can cause you more trouble.
When you try to become perfect, the problem is that you start making more mistakes. The important thing is to analyze those mistakes and next time try to be less perfect and just be good. Okay, Kaushik, I think we have already exceeded the time. So
Yes, sir. Are there any other comments, Dr. Mayank? Jatin sir?
Yes,
Yeah,
Dr. Kaushik.
yes,
Your
Dr. Kaushik.
comments? Yeah, Jatin sir.
Yeah, so overall, Saurabh has comprehensively mentioned all the points that are important both for new surgeons and for experienced ones. So I guess he's covered almost everything that is required to avoid complications.
Dr.
Dr.
Mayank,
Mayank?
sir. So I think this brings us to the end of the session.
Let me just last one question
Yes, sir.
because Patwardhan sir is here. Sir, can you just enumerate few points of managing, say, posterior polar cataracts?
posterior polar cataracts. Okay. So posterior polar cataract, the technique also evolves, as you start doing surgeries. I think one of the most important thing which has changed the way I look at posteropolar cataract is use of the anti-segment OCT. I think everyone has read about the study of anti-segment OCT in posteropolar cataract. Okay. So once you start doing ASOCT for these cases, you will find that 90% of whatever you are facing as posteropolar cataract, in fact, have intact posterior capsule. In those cases, you don't have to really worry about posterior capsule rupture. Now, as far as steps are concerned, in very young patients where the patients are little bit, anxious, I do posterior subtenon block, because what I found is that if the patient keep moving eyes during the surgery, the ocular pressure increases, and that increases the chances of PC rupture. Second is capsulorhexis. You have to have adequate capsulorhexis, but not very large. So I aim for 4.8 millimeter capsulorhexis, because that has been shown to have the best, size for doing a good optic capture in case there is a PC rupture. 4.8 millimeter. That is the best for doing a very perfect and very safe optic capture. Third thing is that mechanical dissection of the anterior capsule is very useful. So you can use simple iris repositor and do 360-degree mechanical dissection, which really helps so that we don't have that stuck epinucleus at the end, which is very important. Hydrodelineation again so there are two types of posterior polar cataracts, very soft, and then there are having nucleus crosses. So very soft cataracts are in fact very easy to manage. You just have to do multiple hydrodelineation, and you can go layer by layer and aspirate the nucleus, and then start aspirating the epinucleus using bimanual. And I always use low bottle height. So now I have Centurion, so I use around 30 to 36 IOP. But even with Constellation or Infinity, I used to use say 50 to 60 bottle height. So whenever you keep bottle height to moderate level, you have less chance of PC rupture. And even if there is a PC rent, usually it doesn't go till the periphery. That is the advantage. So epinucleus removal is the trickiest thing, because you take long time. So here you cannot do it very easily in most of the cases. That mechanical dissection helps in those, because many times it separates that epinucleus from the cortex and you can remove it easily. And every step you have to do aqueous visco exchange, and that is something you have to practice in normal cases. So in your normal cases also try practicing this aqueous visco exchange, because suddenly if you get a PC rent or you are tackling posteropolar cataract, you may not be very good in using non-dominant hand to inject viscoelastic. So try practicing it in your normal cases. So these are a few of the tricks. I think in posteropolar cataract, having again the same thing, optimum. So when the PC rupture happens is when you have sudden shallowing or sudden deepening of the AC. Okay, so both things have to be avoided in posterior polar cataract. And usually this shallowing or deepening may be very momentary. So you can take all the precautions, but you have, momentary, just for a couple of seconds there is shallowing, or couple of seconds there is a, deepening of the anterior chamber, and the PC might rupture. Okay.
All right. If I had to add something to PPC, the incidence of PCR with cases of PPC ranges from 8 to 38%. That is almost 1 out of 3. And there are several modifications which has been mentioned in the literature to overcome. One of which is called the Y technique, or inverted lambda technique, which is proposed by Lee and Lee from UK. So try and create a Y-shaped trench and remove one fragment, so that you can use viscoelastic and try and get the other fragments out. The same one was modified by Dr. Vasavada, and it's called as inside-out technique using BSS. So judicial use of hydrodelineation over hydrodissection, and immobile nucleus, trying to manage immobile nucleus using modified phaco techniques. And of course, careful epinuclear sheet removal as well as cortical removal. Cortex removal, always dissect from the periphery and not to the center. Dissect from periphery, all 360 degree, and finally take it as one gulf. So with all these modifications, the risk may be reduced to 4%. That's what the literature says. And even if there is a PCR, which is expected out of PPC, a well-managed PPC rent, by converting a rent into a primary posterior capsular excess, having the lens in the bag or in the sulcus, is no way inferior to an uneventful phacoemulsification.
Yeah, and I forgot to add that recently one of my technique is published on posteropolar cataract, which is for slightly higher nucleus process, where I use the sideways trenching. So it's just like 4-quadrant technique, but instead of rotating the nucleus, I use the sideways movement of the phaco tip to create that. So for grades maybe 1, 2, 3, it's a useful technique. I think somebody asked about the grade 4 and PPC. I think grade 4 PPC, I think both FACO as well as SICS are difficult, because for SICS also, if you want to remove a grade 4 cataract, you need to have good hydrodissection. Otherwise, you will not be able to prolapse out this grade 4 cataract. So in this case, I think you are relying on the PC, the posterior capsule integrity. If it is a pseudo PPC, you will get a good result. If it is a true PPC, then you are going to have PC rupture in grade 4 cataract with PPC. Another good technique which I have seen, that's why I think the anti-segment OCT has made a big difference. So the moment I see a intact PC in, you try world's every technique of PPC, it will work. If there is a PC rupture already, then you have to be really careful and try to minimize chances of it rupturing even further. Now, another good thing which I have seen, I think Dr. Kamaljit doing in case of grade 4 cataract with PPC, what he does is that he makes a trench sitting at, say, temporally, and then he sits superiorly, makes another incision for phaco, and then makes another trench. So instead of rotating the nucleus, he himself shifts from one to another. So same like my sideways trenching method, but instead of doing a sideways movement, he shifts himself and does a trench. So it's like a 4-quadrant done from 2 incisions without rotating, and then each quadrant is taken out. So if you have got this grade 4 PPC tomorrow, I think you can try this technique. Luckily, those cases are rare, so we are safe.
Thank you, sir, for your expert comments. And probably it is very important. Once you have, sir, a posterior capsular rupture, will you go ahead with putting a 3-piece IL with a posterior capture, or you will put it in the sulcus itself?
Yeah. So in many cases of PPC, if you are careful during the surgery, you can convert this PC rupture into posterior capsular excess. So I have cases where I could place the same single piece IL in the bag in case of PPC. But if it is ruptured equator to equator, of course, you cannot place anything in the bag most often. So in that case, I think best idea to use 3-piece in the sulcus with optic capture. So the advantage of optic capture is that the chances of decentration of this IL is very less, and these are particularly young patients. So you want that IL to be stable over a very long period, and you are covering the sharp edges of this 3-piece IL with the anterior capsule. So chances of any iris irritation in the long term is also reduced. So that's why you have to plan a 4.8 millimeter capsule axis. So you get the optic capture in these cases.
I agree, and I'll do the same thing as you said.
Yeah. And one more important thing, because you are tackling young patient, you want also the refractive correction to be perfect. So if you have already planned optic capture, remember that you have to use the emmetropic IL power. So you should not reduce the IL power, which we do for sulcus placement. Okay. Otherwise, what will happen is that patient will end up with some hyperopia, and you don't want patient to be hyperopic. So plan before you inject 3-piece IL in the eye. Just plan whether you are going to do optic capture or not, and according to take the IL power.
Thank you, sir.
Thank you.
So this brings us to the end of the session. I would like to thank Dr. Sourabh sir I am sure this session was really helpful to all of us, especially the fellows. I would also like to thank the stellar panel that we had tonight, Dr. Jatin sir, Dr. Gaurav sir, Dr. Lionel sir, Dr. Mayank sir. Also, I would like to take this opportunity to invite all of you for our next session, which is on 19th February 2025. So thank you everyone. Dr. Kaushik sir.
Thank you. I take this opportunity to thank Saurabh sir, who has been my senior from AIMS. There are so many things to learn from him, and I'll request all of the fellows to please visit his like videos, specifically the videos on thinking process of things like capsulorhexis, etc. They actually add a lot to your like own practice, and you'll definitely improve on that. And as sir said, try to capture your videos and see those videos and try to find out what deviations you did during surgery. That is very important. Unless you know the deviations from the standard protocol, then you will know that yes, I am not using the left hand properly. So that will help you improve. I thank Lionel sir, Gaurav sir, Jatin sir, Dr. Mayank uh, for being the expert panelist here. I thank all the audience for staying so late, and I think we learned something new today. I take this opportunity to thank my colleagues in ASGK Academic Cell, Dr. Ganesh, Dr. Mayank, and Dr. Atul. And I thank the uh, moderators, Dr. Lipi and Dr. Aparna. Thank you. Have a good day. Thank you.
Thank you, Kaushik. And before we end, we conduct a annual workshop. So this year it is from 19 to 22nd June in Kolhapur. And this time we will be also doing some hands-on training, supervised, surgeries for, because I have found that many surgeons request me because they are not probably beginners, but they want to improve. So we will be also conducting a supervised session where we'll be observing how they operate and we'll give them guidance. So it will be a nice session. So if anybody wants to attend, they can contact me. Thank you, Kaushik, for this kind invitation to entire group. Thank you so much.
Yeah, thank you so much.
Thank you so much.
Good night, all of you.
Bye bye.